Thank you, Kavinder. The topic that I am going to discuss today is upper lid ptosis before the scalpel. So during my presentation, my main objective is to help you to understand the importance of pre-operative planning before ptosis surgery. So you can ensure you get the desired outcome as well as you avoid unwanted surprises. And then also to set realistic and safe goals that you will not have unhappy patient at the end. So the topics I'm going to cover are these and no financial disclosure. So to start with, I like to share this patient. So the patient came with the right small eye. If you look carefully, the post-op photo, do you see anything odd? I had done the surgery on the other side, the left side, not on the right side. So why? The reason is the patient had actually the left upper lid retraction, not the right, the true ptosis. And this is, again, came with left small eye. It's obvious that the patient has hypertropia, so that the cornea get covered more with the natural, normal upper lid. So with these two cases, I want to bring the first thing that we have to work out is to find out whether this patient is having a really true ptosis or whether anything that mimic ptosis, that is pseudotosis. So the pseudotosis give a false impression of a ptosis in a patient coming with a small eye complaint. So the causes for pseudotosis can be ipsilateral or contralateral. So this lady has left a small eye, and actually if you see in the picture below, so you can see the patient is having an ophthalmosis, and actually this is a case of orbital floor fracture. And when you have the dermatochalasis, the skin fold can come over the lid margin and hang forward so that it gives the appearance of a small palpable fissure, so giving rise to a pseudotosis. The brow ptosis, where you have the facial nerve palsy, when the brow come down, it carries the upper part of the lid skin above the lid crease downwards, and again same as the dermatochalasis, it can come down below the lid margin, giving rise to an appearance of a small eye. And this is an interesting case. If you see this lady, so she got left small eye. But if you look carefully, the right has brow ptosis and the mouth is deviated to the left side. So actually it's, even though it's the left side small eye, but the right eye facial nerve palsy. How do you get a larger eye with the facial nerve palsy? We know that when the orbicularis is paralyzed in the facial nerve palsy, unopposed levator muscle can cause lid retraction. So the facial nerve palsy can come with both ptosis as well as lid retraction on different occasions. So this is another case. So this gentleman came with the right eye ptosis, and when covering the other eye, of course you can see his eye is quite normal. And the bottom picture shows that his eyes are not aligned, the right eye is deviated downwards. Actually here, the patient is subconsciously keep his right eye closed to get rid of double vision. The contralateral causes for pseudotosis, we discussed one, that is upper lid retraction, and the other one is the proptosis. As you see, this patient has a right eye small eye, but exact problem is left eye proptosis, giving rise to a kind of appearance of a small eye on the left side, and this is actually a case of Graves' orbitopathy. So having excluded pseudotosis and confirming true ptosis, can we go ahead with ptosis surgery straight away? No. You see this patient. So this patient has right eye, small eye. So all the findings were normal, except till you see the fornix. So you see a fornix lesion, and that is the cause for mechanical ptosis on that side. And this lady, You can see in the left hand side, so there's a lady with a small eye. Actually, it's a case of hemifacial spasm. When you get the spasm, that eyes tend to get small and looks ptotic. And of course, I can't get the video played, but the right hand patient also have a left small eye, and again it's due to a hemifacial spasm. So with this, so we need to work out the cause for ptosis. That's the most important thing before surgery. So to understand why you get what the factors affecting the lid position, so there are 3 factors which keep the lid up: the levator, muller, and the frontalis. And there are another 3 factors which lower the lid, that is orbicularis, weight, and the friction. And if you think in this way, you can really work out the cause. And of course, conventionally, the causes are categorized as neurogenic, muscular, aponeurotic, and mechanical. So I think you're familiar with the causes. The one important thing that I just want to emphasize is the hemifacial spasm as under neurology, as well as under mechanical, you can get heavy skin. Heavy skin, as you see it, extreme case of dermatochalasis as well as brow ptosis. So this lady, 54 years, came with small left eye since early childhood, but since of recently she got a worsening of ptosis. The examination showed limited elevation, high lid crease, and elevator function of 10. So this is actually a case of pre-existing congenital ptosis developing a secondary levator dehiscence. So sometimes there can be 2 causes for the ptosis. So that workout is very, very important, and then of course you can decide the treatment. Of course, there are certain conditions which can be treated medically. For example, myasthenia, hemifacial spasm with botulinum toxin, myositis with steroid. And if there's a mechanical irritation, we can manage with lubricant. And one thing is the alpha agonist. Alpha agonist trigger the Muller muscle. So there's a drug called oxymethicillin hydrochloride solution, 0.1%. It is alpha agonist. This is FDA approval for acquired ptosis, particularly after Botox. So it's used as a once daily dose, gives about 1 to 2 millimeter lift, and it lasts for about 6 hours. But it is only for temporary use. It has side effects like mydriasis, blurred vision, inflammation, blood pressure rise, and so on. And it costs about 50,000, more than 50,000 rupees per month supply. And of course, surgical intervention other than the ptosis surgery are required for mechanical causes. Like when you have a heavy lid or lump and fornix lesions, we have to do the surgical correction, but not the ptosis surgery. As you see in these pictures, you can see left-hand side, you can see a patient with S-shaped ptosis caused by neurofibromatosis. And the second one is having extreme dermatochalasis leading to heaviness and lowering the upper lid downward. And here it's not a pseudotosis, it's a mechanical ptosis due to the weight of the skin. And again, on the right-hand side, you can see again extreme brow ptosis. And in addition to coming down, it has pushed the lid downward. You can compare with the right eye. The lid margin has come down. So the brow ptosis and the dermatochalasis, in addition to causing pseudotosis, where the lid margin is in normal position, it can be a mechanical cause as well, where you get the lid margin downwards. And this is the case of blepharochalasis, where you get the swollen upper lid, which gives rise to a ptosis, mechanical ptosis. So this is a patient with facial nopose, which has recovered partly. So as you see, the brow is down, but luckily, as you see in the second picture, his lid closure has recovered. So even lifting the brow, his lid closure is spared. So this helps us to do a brow lift. So you can get the lid margin correct, as well as get rid of the brow ptosis. So after identify the cause then and deciding the surgery, then you have to find out the surgical technique. So if you don't do it properly, you will end up with problems. So this boy who had dog attack had, with poor levator function, had more than 7 brow suspensions. Without noticing that he has paralyzed brow due to the laceration and in the lateral side, so it's denervate the frontalis muscle, so there's no point doing brow suspension in this kind of patient. And this is another interesting case, congenital third nerve palsy. And if you miss this, you can have problems. I have seen quite a few non-ophthalmic surgeons doing levator surgeries for this kind of patients, coming up with no results. Obviously, when you have a third nerve palsy, the levator is not functioning, so there's no point doing levator surgery. So the surgical technique, so we can have either increase levator muscle augmentation, molar muscle augmentation, or frontalis augmentation. Those are the options that we have. And the downward forces we usually manage with non-ptosis, other means which we discussed earlier. So to decide the muscle, we have to find the function. So the levator function has to be checked, and then the molar function has to be checked with the phenylephrine test. And the frontalis, of course, we have to ask the patient to look up and see whether the frontalis is working before doing brow suspension. And if you decide to do levator surgery, you can do the levator repair, levator where you reattach the detached levator, and you can do the levator advancement. And in case of poor levator function, range of 3 to 4, 5, you can do augmented one where you can go up to the Whitnall ligament. You can dissect the horns, as well as can combine with molar muscle resection along with levator advancement. Molar muscle surgeries are usually done through the conjunctiva, so either molar muscle conjunctive resection or the muscle and conjunctiva, or it can combine with adjacent tarsal plate, that is Fasanella servat procedure. And the frontalis surgeries, we commonly know the frontalis suspension, but additionally there are frontalis tendon advancement is possible, where you bring the tendon and attach the levator, attach the tarsal plate, or you can Lemagni procedure, where you get the levator muscle belly and reattach to the frontalis, so expecting that frontalis, the nerves to frontalis muscle innervate the levator, and once that we can do a second levator advancement to get this. This is basically for Marcus Ganjovinki. And once you plan this, decide the surgical technique, then of course we have to decide about whether we do bilateral surgery for unilateral ptosis. This is unique instances where you, when you have latent ptosis on the other side. For example, in this lady, the right eye ptosis, and of course there's a compensated latent ptosis on the left side. If you do only the right side, left eye will come down, so we have to do the bilateral ptosis. Same way when you do the brow suspension, if you want to symmetrical results, then of course you have to do the brow suspension both sides. And then you have to decide the lid margin where you have to have. So there, of course, we know it's about in 1 millimeter, but from the upper limbus, but it's not case all the time. When you have the racial variations, there can be familial deep-seated eyes, and sometimes the male patients might have heavy brow with small eyelid, then we don't try to meddle with that. However, if you have acquired bilateral ptosis, we can refer the old photos to find out where has been the lid previously. And of course, unilateral ptosis, we can use the normal side as a reference for the lid margin. So this child had normal correct surgery on the left side with lid margin at 1 millimeter from the lid. But this gentleman with left eye ptosis has a very poor elevation and the muscles. So we had to do an undercorrection. If you see the post-op operation, there is a good improvement, but we have achieved slight undercorrection, so the lid closure is intact. Similarly, when you have blink lag ophthalmosis, as well as when there's impaired Bell's, we had to do undercorrection. And so when you have both Bell's deficiency as well as lag ophthalmosis, of course, we have to go for lid clutches. So the Marcus Ganjovinking and third nerve palsy, where you have the synkinetic movement, so either you can combine with the brow suspension, or if you need, you can go with the undercorrected levator surgery. And finally, we need a kind of 3D contouring for aesthetic appearance and the medial canthal and lateral canthal. If you see these pictures, so the lady had a left side ptosis. We had to give a lid fold and a skin crease during the surgery. And this child had a very slight lid crease, so we had to go a deep lid crease. And this one again had a higher lid crease, so we had to go to lower lid crease. And she had a deep sulcus, so we had to go symmetrical deep hollowness for the lid. And she didn't have a pretarsal show, so we gave a pretarsal show during the ptosis surgery. And of course, the canthus, if there's inferior dystropia, we had to correct before the ptosis. And the medial canthus, again, we had to correct before the ptosis surgery. So canthus should be addressed before that. And finally, before the operations, we have to optimize the skin for any skin inflammation and thinning, ocular surface inflammation and dryness, and of course, the strabismus has to be addressed before the surgery. Thank you.